Hello, good morning. This is Sarah Kelly with the Kelly Clinic, and this is our very first YouTube video. I've been getting a lot of requests from people to do some teaching about the diagnosis of EDS and how I specifically come to the conclusion or the suspicion that someone might have EDS. So I thought we'd take some time this morning just to go over the basic diagnosis and description of disease with EDS. Because as many of you know, I actually have EDS type 3 or hypermobility EDS type H, as we'll learn in this presentation, which is the most common form of Ehlers Danlos Syndrome. So first I want to start with a case presentation that highlights some of the findings and history elements that make me suspect that someone might actually have EDS when they come to me or another provider with different sort of unusual complaints than one would typically expect with EDS. And this case is fictional. It just kind of groups together a number of symptoms that I've seen from a variety of different cases, but wouldn't atypically see in one individual case. So if you're following along on the presentation on the PowerPoint, which is below the YouTube channel, you can just click on that link and follow the presentation along with me. We're on slide number 2. So this is a 52-year-old married female dentist in your local community or any local community who has 2 adult children. And she's coming to clinic as a new patient complaining of chronic diarrhea. Her past medical history is notable for a history of depression. She's been told she has generalized anxiety. She might have thyroid disease of some type. She's not sure what kind, but she's on Synthroid. She's also perimenopausal, possibly menopausal at this point, and has recently been diagnosed with fibromyalgia. She's on fluoxetine or Prozac and Synthroid or levothyroxine, and those are the only medications or supplements that she takes. She has no drug allergies, and she's had no surgeries, with the exception of 2 normal spontaneous vaginal deliveries of her otherwise healthy children that had no complications at birth. And she complains of intermittent diarrhea and constipation, sort of IBS-like symptoms that have been going on for a number of years. She wonders if these GI complaints could be related to something that she possibly ate, some allergy that she's developed, or some sort of sensitivity to chemicals in her diet. She also brings up the possibility that maybe her symptoms could be an infection, possibly related to her travel for work. But she otherwise denies fevers, chills, or night sweats. She's had no significant changes in her weight, with the exception of maybe a gradual increase in weight over the last 10 to 12 years. She does also mention that she's got a fair amount of fatigue that limits her in her activities of daily living. So occasionally she'll find herself just flat out exhausted and unable to participate in normal activities of daily living, including household chores. And that really has not improved much with the treatment of her thyroid disease or with the addition of Synthroid. So she's wondering why she's still feeling all that fatigue. She further expresses some concerns about increasing episodes of debilitating headaches, and at times notes that she's unable to adequately focus. Some people have maybe suggested that she has ADHD or just difficulty with focusing, particularly in the afternoon, she notes. Occasionally she has palpitations. Sometimes she notices that her heart races or flutters when she stands up too quickly. She doesn't usually get dizzy, but occasionally can get dizzy with that activity too. Others have labeled her as a hypochondriac, saying that she has an exorbitant number of health concerns and symptoms, and maybe it's just overly sensitive. Some doctors have implied to her that her symptoms are not real or not related to some identifiable organic disease, and therefore maybe psychiatrically mediated. And like we mentioned before, she was recently diagnosed with fibromyalgia, and she notices that maybe her daughter might have fibromyalgia too, or some of these similar symptoms, because she's also complaining of a lot of fatigue and changes in bowel habits and occasional palpitations. So what strikes me about this case is what strikes me about many EDS cases in that there are a lot of seemingly unrelated symptoms and complaints that just really don't seem to be well connected. And so one of my favorite quotes is from Laura, my favorite quotes about EDS, I should say, is from Laura Bloom, who says, if you cannot connect the issues, think connective tissues. And so this case really highlights that exact thing, and that, you know, these symptoms and complaints are all seemingly unrelated. So what is EDS? EDS is a group of inherited disorders that are caused by abnormalities in collagen production in the body. These abnormalities either result in decreased amounts of collagen or decreased functionality of collagen. So the collagen itself either doesn't function appropriately within the body, it isn't correctly made or manufactured, or it's not manufactured in adequate amounts, and therefore healing becomes a problem. And just as a review, collagen has several subtypes, but it's present in nearly every tissue and organ system in the body. And so when you have an abnormality in your collagen or in one of your collagen molecules in your body, it can potentially affect almost every organ system. And therefore, patients often find themselves going to specialists within a vast, wide variety of fields trying to get answers to their complaints or their symptoms. EDS is associated with many widespread complications and symptoms. And so the tissues that are most commonly involved in the disease, though, are skin, joints, and blood vessel walls or organ walls. There are 6 major types of EDS. They, as I mentioned before, vary in their specific cause and presentation. They each are dependent on the form of collagen that's affected by that particular disease. So the disease manifestations and the disease findings are dependent on which type of collagen is affected. The recorded prevalence of EDS is about 1 in 2,500 for all comers. However, many people suspect that this vastly underestimates the amount of EDS present in the world and in the United States today, mainly because it's often misdiagnosed or undiagnosed. And this is due to a lack of recognition, mainly from care providers and medical personnel. Most of us in medical school are trained that EDS is associated with loosey-goosey joints and maybe circus performers, etc., but not much more than that. And there's quite a bit more, as we'll learn today, to EDS, and quite a bit more that's important clinically than just being loose-jointed. Most forms of EDS are inherited in an autosomal dominant pattern, meaning it only requires one gene from one parent in order to express the disease or have the disease. So the major symptoms of EDS, and this goes for all forms of EDS, are stretchy, loose, and or velvety skin, skin that maybe doesn't wrinkle as much as maybe other folks. So I often say that this is probably the one good thing about having EDS, in that we do not generally form wrinkles as quickly as maybe other folks our age, and therefore we look a little bit younger than stated age, which is certainly a nice finding when you deal with a lot of other negative things associated with disease. We also have flexible joints with hypermobility. This can cause chronic pain and damage, reactive muscle pain and tightening, muscle knots. The muscles react in order to try and compensate for those loose joints by tightening up. And so people often have symptoms that take them to the chiropractor or the massage therapist, when in reality it's coming from the joint and not the tense, tight muscles themselves. Many forms of EDS are associated with abnormal wound healing, wounds opening, dehiscing, sutures coming out, cuts and injuries not healing correctly, or forming weak scars. So that's an important exam finding to tip you off to EDS. Along with the joint findings, people commonly can dislocate their joints either on command or inadvertently, or they can have partial dislocations or so-called subluxations, where the joints themselves simply partially dislocate or become malformed due to the laxity of the joint, but don't entirely come out of joint. Many people with with these sort of symptoms in their fingers describe having to put their fingers back into joint when cutting up their food with utensils while they're eating or writing. I know I have those problems, for example. We also tend to have easy bruising. Many people with EDS wake up in the morning covered in bruises from just rolling over in their sleep. And this can be a little bit disconcerting, but when you understand that in terms of the fact that the blood vessel walls are a little weak and therefore easily broken, the easy bruisability makes some sense. And then the more troublesome and more worrisome symptoms of EDS that really need to be screened for and carefully managed include the vascular complications such as aneurysms, dilations of vessels and ruptures of vessels, and valvular heart disease, as well as organ ruptures and hernia formation. And those things, although they're very rare, are something that we need to check for and be vigilant in all people with EDS. So the next slide shows some of the associated skin findings and joint findings with typical EDS, and you can find these in all folks with EDS. The picture to the right shows the extension of the fingers, which any extension to 90 or beyond is considered abnormal. She also, you can see, has some subluxation of the distal joints of the fingers as well in that picture. But regardless, that's hyperextensibility of the fingers. On the left, that is a representation of the typical skin laxity seen with folks with EDS. And most of us can probably pull our skin off of our hand like that and notice that there are radiating wrinkles that cover the entire hand and go into the fingers instead of just staying locally at that loose skin. So that's defined as abnormal skin laxity. The next picture is just a really great poster. It's a PR piece that all the folks in EDS have been trying to get out as far as the word on EDS and the things that people should look for as far as hypermobility. And so just take a look at that. I think many of you will recognize a lot of these findings. Like, for example, the young girl sitting with her legs and her knees underneath her. I know I sat like that as a child, and likely as a result have had some damage to my hips as a result of that. But take a look at that, and it's good to be aware of some of the things that you might find in people with EDS who have the disease without knowing it. The next slide is the Beighton score, which forms the foundation of much of the foundation of the diagnosis of EDS. And so if you look at each of these, there's 5 specific exam findings. Each, if you can do the maneuver, it's considered 1 point, with each side, right and left, being evaluated, and a total score of up to 9 points. This is what helps clinicians determine whether or not the hypermobility that people are experiencing is not just isolated to one joint, but more generalizable. So many clinicians are going to use the Beighton score then to follow, track, and identify hypermobility in a global sense. But more important than hypermobility and skin findings in EDS are some of the associated conditions. And I find that these conditions and symptoms often cause some of the worst complications of disease, and are what, ironically, are the things that we don't necessarily recognize as being associated with EDS. These things include autoimmune thyroid disease, or so-called Hashimoto's thyroiditis or thyroid disease, chronic pelvic pain from endometriosis and or pelvic congestion syndrome. People commonly have depression, anxiety, and even obsessive compulsive disorder. It's not clear whether this is a primary association with EDS, or if these so-called psychological manifestations are secondary to some of the things that we deal with in having EDS and being misdiagnosed and being passed around from specialist to specialist without a good answer or treatment for our symptoms. Another dreaded complication beyond the vascular complications with EDS is something called Chiari malformation, where Parts of the brain can herniate and slip into areas where they're not supposed to be because those areas are lax. That's a specific problem that needs to be dealt with specific specialists who are not only specialized in dealing with Chiari malformation, but have some experience in dealing with EDS patients with Chiari. Patients often complain of GI symptoms that seem seemingly like the patient that we presented in the initial case. Could be related to irritable bowel syndrome. This is often related to something called mast cell activation disorder and leaky gut, which is a big topic within the integrative medicine realm. We will most certainly do some more talks about these two entities because I think that this is an area that is rapidly evolving and catching a lot more notoriety as far as its relationship to not only EDS, but lots of different chronic diseases. People with EDS get autonomic dysfunction, which presents as dysregulations in the fight or flight symptoms or systems of the body, so that maybe when blood pressure is supposed to rise, when we stand up, it falls. We can get palpitations upon standing too quickly, which is often related to something called postural orthostatic tachycardia syndrome, or POTS. But this autonomic dysfunction and POTS are another area of EDS that receive a lot of attention and really do require a very mindful, specialty-driven focus to address and treat. And then one of the conditions that I see not only in EDS patients, but causing tremendous disability in patients with all kinds of other unrelated conditions is temporal mandibular joint dysfunction, or so-called TMJ. This can cause reactive muscle changes in the head and the neck that contribute to chronic, sometimes daily headaches. There are a variety of other causes of chronic daily headache that can occur in EDS, including nerve root impingement syndromes, migraines, tension-type headaches, and even cluster-type headaches. So having somebody who is mindful of EDS and the potential complications as far as headaches is really important when seeking treatment for EDS and EDS-related headaches. And then finally, something that is just really interesting that we find a lot in EDS is that we all tend to have a slight decreased, reduced responsiveness to anesthetics and sometimes opiate pain medications. And so it's not uncommon for me to find patients who say that they have to be numbed several times at the dentist because the numbing quote doesn't take. Epidurals not functioning correctly. These are all not really so much a sign of abnormality in your body, but that another reflection that you possibly have EDS. And then finally, another thing that gets brought up a lot is this association between EDS and clumsiness, falls, and trauma-type injuries. And this is like many things with EDS, multifactorial, but often related to decreased proprioception or joint position sense. So because our joints are lax, we're less, our brain is less capable of accurately pinpointing where our joints are in space. And this can lead to problems with tripping, overjudging objects, and maybe smashing fingers into walls or doors as we're reaching for a doorknob because we don't sense exactly where our fingers are in space because the joints in our fingers maybe are not adequately positioned and are lax. But we also develop problems with clumsiness and falling because of lack of muscular strength, which can be addressed through some of the treatment modalities that we use for EDS. The natural history of EDS is important to recognize and understand because it has an important impact on how patients present in the clinic with symptoms. In childhood, children are naturally somewhat lax. And so it's not necessarily abnormal to see a child who has hyperextensive knees or knock knees, hyperextensive ankles, wrists. But as over time, if that hypermobility doesn't tighten up and continues to progress, that could be a sign of EDS. Also, kids with EDS often have chronic repetitive complaints of very nonspecific type pains that parents write off as growing pains, just aching joints, just pain from sleeping on your neck wrong or your leg wrong. But these kids really often are just more insistent and regular in their complaints about nonspecific migrating, multi-joint, multi-muscular type symptoms. And they can also have headaches, which in my mind is somewhat a red flag in children, because a lot of children really don't experience headaches as a normal part of development. And then finally, just a note about kids with EDS, fatigue can be very debilitating and prominent in our disease, not only in children, but also in adults. And so this can manifest as depression in children. And it's something that we should very carefully screen for and pick up for in children with EDS. And these kids also, just a quick note, may also have an increased risk of fracture, which is what makes identifying them and preventing further disability and disease important. But as children grow into young adulthood, they tend to become a little bit less symptomatic in regards to their EDS. So, and this relates possibly to increased muscle mass that relates to increased joint strength and stability, but also children with EDS tend to pursue activities or sports in which their hypermobility is promoted. So sports such as gymnastics, dancing, karate, etc. And that needs to be carefully managed and assessed as far as risk down the line. But eventually, once we become more mature into adulthood, we've accumulated a number of years of joint damage related to the laxity of the joints and soft tissue injuries that are chronic, repetitive, and continually occur as a result of instability. And this will later relate to degenerative changes in degenerative arthritis, leading to a restrictive phase of disease. So it's not uncommon to see an adult who has widespread multi-joint degenerative arthritis and maybe some of the other conditions that we associate with EDS. And then I questioned them a little bit about what they were like as children, and you find that they were very hypermobile. Maybe they used to be able to do the splits. They were gymnasts. You know, they were always told they were very flexible, etc. And so it's important to know that the presentation in adulthood is not the same as it is for children or young adulthood. And the same goes too as well for individuals. There's a lot of individual variability in EDS. So just having an open mind and knowing what the natural history of disease is very important. So then what is the differential diagnosis? Patients who actually have EDS come in with all sorts of different diagnoses on their charts, having received different possible diagnoses from doctors. And these include things like fibromyalgia, Lyme disease, chronic Lyme disease, reactive arthritis, seronegative arthritis, rheumatoid arthritis, lupus. But even more concerning is a lot of folks have quite a bit of disability and despair simply because they've been told that this is in their head, it's related to a psychiatric disease, they have something called Munchausen syndrome, or maybe even a conversion disorder in which their physical symptoms really are more of a manifestation of something going on mentally or psychologically, which honestly is not the case in EDS. This is an organic disease. And so getting that kind of label can be very damaging to us because it contributes to self-guilt, loathing, disability, and further despair. So it's really important, and there's a huge push nationwide to get the word out about Ehlers Danlos and invisible disabilities and making the invisible visible, as far as healthcare providers and teachers, sports coaches, etc. So expect to see more of this over the next coming years. And then finally, it's important to note that within the differential diagnosis of EDS are other connective tissue disorders. So disorders that affect the collagen and other collagen processing proteins in different ways than maybe EDS does. And those include things like Marfan syndrome, certain forms of osteogenesis imperfecta, conditions like Stickler syndrome, and even achondroplasia. But most of those are quite rare and usually not ultimately what we find to be the case in most of the people that meet most of the criteria for EDS. We do have genetic tests for a lot of those too as well, so that helps us rule those out when we employ the genetic testing that's specific for the different collagen disorders. So I'd like to just briefly go through the major types of EDS. The first type, which has been classically called type 1 or type 2, but is referred to as classical type or classic type EDS, is manifested mainly by its symptoms in the skin and the joints. It tends to be a little bit more heavy in the skin findings. These people are plagued with poor wound healing, poor retention of sutures, wide gaping open scars that don't close in a nice clean linear line. They do have generalized hypersensibility of joints and skin and easy bruising, as we see in other types of EDS, but primarily a lot of their symptoms come from the skin. And that's what makes classic a little bit more unique than the hypermobility type, is that the skin findings are far more prominent. Classic type is also associated with congenital dislocations of the hips, scoliosis, as well as mitral valve prolapse, which we could see really in any type of EDS, but maybe more commonly in classical type than in hypermobility type. Next slide just shows some of the findings that we might see in classic type. The findings to the right, the hypersensibility of the fingers and the laxity of the skin, are not particularly unusual among all forms of EDS. But the findings to the left, the wrinkled, sort of redundant scar tissue that, if you were able to test it, would have low tensile strength, is one of the classic findings in classic type. So seeing and looking at a patient's scars is important, and be sure if you have scars like these to point them out to your provider so that they're aware that this might be classic type EDS. The hypermobility type, or type 3, is far more common than any of the other types. It's reported to occur in up to 1 in 5,000 people, but it's probably much higher than that. I've even seen people say as high as 1 in 250 people. And that's mainly because it's poorly recognized, under-recognized, and under-diagnosed by primary care and other healthcare providers. The exact cause of hypermobility type is unknown, and there's no genetic test currently available to test for it. There are a number of theories out there about why we have this disease without a specific known mutation in collagen. That's beyond the scope of this talk, but something that we will approach in later videos. But know that as of right now, we don't know what causes hypermobility type of EDS. It does appear to adhere to an autosomal dominant pattern of inheritance, meaning one proposed gene is required to inherit this disease. Again, we don't know what that gene is. But if you look back historically over time and follow people with EDS type H, it's usually pretty clear that you can track the symptoms along one side of the family, and it goes back usually several generations if you look and think about proposed possible diagnoses of EDS in folks who were around before we were even making the diagnosis of EDS. But the cardinal feature in hypermobility type is, as you would guess, hypermobility or joint hyperextensibility. Again, chronic degenerative joint disease and restriction occurs in the advanced phases, although premature osteoarthritis is also reported. So people may develop osteoarthritis much younger than you would otherwise predict, and that's related to trauma. There tends to be less skin involvement than you see maybe in classic type, as we already mentioned, And again, remember that mitral valve prolapse can occur in this type as well as it can in classical type or even in vascular type. The next couple slides just show pictures of what we can see in the hypermobility type. You know, placing the hands together like this, our fingers extend far beyond the vertical median. When we just extend our fingers naturally, so this is not me pushing my fingers out or straining my muscles in order to do this. This is just how my hands actually rest, much like the picture that you see in the slide. We get hypermobility, as you can see in the next slide, in our feet, in our knees, in our toes, in our thumbs, which a lot of people can reach to their forearms. In fact, one of the most sensitive findings for EDS on physical exam in children is flat feet. You know, children do not have the years and trauma accumulated in order to have fallen arches, and so they really shouldn't have fallen arches at a young age. And so if they do, that's maybe an indication that their connective tissues are not normal. The next type, the vascular type, or type 4, is the most serious of all of the types of EDS, mainly due to the vascular complications that are common in this type. It's estimated to occur in 1 in 250,000 people. And these are people who are prone to ruptured, dissected arteries or aneurysms of arteries or veins. They can also have intestinal or uterine ruptures, also again related to abnormalities in that connective tissue that lines those hollow, viscous type organs. Like everybody else with EDS, these people get easy bruising. They have the thin, soft skin. What's different with vascular type is that their skin tends to be translucent, which is normal somewhat in childhood, but should not persist into adulthood. That can lead to the visibility of veins beneath the skin, particularly on the chest. So people can get diagnosed with a variety of different conditions, such as thoracic outlet syndrome, that lead to visibility of veins under the skin, when really it's just actually the skin itself is translucent and the veins are dilated. It's not maybe related to some mechanical backup of pressure due to some other cause, which is what we are classically taught in medicine. And then folks with vascular type EDS often have what we call a syndromic appearance. They have delicate facial features. Their eyes are often almond-shaped, deeply recessed into the skull. They have thin nose, a thin lip, usually a thin upper lip, but sometimes thin upper and lower lip. Their cheeks can be a little sunken, and they can have a small chin, or microagnathia, as that's called. And then finally, sometimes you'll see a flattening or widening of the space between the eyebrows and the eyes. But in general, it's good to remember that those with vascular type EDS have somewhat delicate, feminine-like features. And if you remember that, you might be able to pick up some of the more subtle findings of the disease. The joint involvement tends to be variable, so these people aren't necessarily as hypermobile as the people with EDS hypermobility type. And that's mainly because this affects type 3 collagen, which is more prominent in the vessels and the vasculature than in the joints and the ligaments. The next slide shows a picture of some of the exam findings typical in vascular type EDS. I'll just bring your attention to the picture of that wide open mouth. You see that this person has a very high arched palate and a somewhat small mouth. It's not uncommon for people with all types of EDS to be told that they have a small mouth size, they have a high arched palate, maybe they have trouble getting their mouth open wide enough at the dentist for cleanings and various different dental procedures. That can be related to the size of their mouth, but also to the fact that they have TMJ and are having some impingement or subluxation type symptoms in their TMJ that prohibit them from opening their mouth wide enough for cleanings. The folks with vascular type EDS really have a more prominent high arched palate and narrow soft palate than all comers with EDS, but you do see this general finding in all forms of EDS. The other types of EDS, kyphoscoliosis, arthrochalasia, dermatosparaxis, which are types 6, 7, A, B, and C, are much rarer and often confined to isolated family genetic studies. And so at this point, I will not spend a lot of time on those, but know that there are other types that have a rarer presentation and maybe a specific disease finding, like, for example, scoliosis and the kyphoscoliosis type, that help you key off to that being the particular type. But again, there's probably going to be a family history when you see these kind of folks in practice. Unless, of course, this is the first person in the family being diagnosed, which makes it inherently more difficult. So then what's important in making a diagnosis of EDS? It's important to take a very thorough family history, but also genetic and family history, and even sketch out a pedigree. Being able to ascertain that some of these symptoms are occurring in an autosomal dominant type pattern of inheritance can increase your suspicion that you're dealing with EDS. The exam needs to be focused particularly on the joints and the soft tissues, but not limited in the sense that the effects of EDS can occur in all of the organ systems, from cardiovascular to ENT to GI. And so doing a very thorough, well-rounded, full physical exam is important in all people with EDS, keeping in mind some of the things that we tend to develop. I always like to rule out rheumatologic disease with laboratory studies as a part of my initial workup for EDS. And most of the time I do offer genetic testing, mainly to rule out the forms of EDS that have disease-causing mutations and forms that can be tested for genetically. In fact, right now I'm utilizing a saliva-based test out of the University of Washington that happens to have the same sensitivity and specificity as a blood-based PCR test for the connective tissue disorders. And so that's helpful in my practice for ruling out some of the more rare and more dangerous types of EDS than the classic EDS-H, which does not have a specific treatment and is managed maybe more from a lifestyle management perspective than from a screening perspective, like would occur in vascular type EDS. And then other tests that can be employed in the workup of Ehlers Danlos are skin biopsies. There's a urine test for the kyphoscoliosis type. And then there's specific testing that can sometimes be done in select labs for prenatal and pre-implantation testing on fetuses to determine, particularly in the cases of EDS that are maybe more dangerous and potentially fatal in utero. So those are available, maybe a little more research and experimentally oriented at this point, though. So as far as treatment, again, there's no specific cure available for any forms of EDS. The goal then is to manage the symptoms and prevent complications, mainly complications of further joint degeneration, joint injury and inflammation that lead to restriction and pain underlying in older age. It's important to screen people with EDS for heart abnormalities and vascular abnormalities with echocardiogram and aortic ultrasounds, looking for aortic root dilatation or dilatation of the aorta in the abdomen. So I usually order echocardiogram and abdominal ultrasound on my EDS screenings. And I make a special note to have the radiologist look for aortic root and aortic dilatation, NOS. I also like to do DEXA scans on my patients because there is an association with EDS and osteoporosis, particularly in the later phases of disease. And then we tend to do a lot of CNS imaging, whether through MRI or CT, mainly in the workup of EDS-related headache disease, which has quite a vast differential diagnosis, and again will be a topic that we'll discuss later. I plan to give an entire talk on headache disorder and EDS. But ultimately, the primary goal and the primary intervention that we can perform as healthcare providers in EDS is patient education, genetic counseling. We really need to teach patients how to manage their disease in a way that works for them and keeps them active and busy in doing the things that they love to do and that bring them joy, because that's a huge part of managing our disease, is keeping our mental status and spirits up, and preventing depression and despair and disability. So for that, I usually recommend a physical therapy rehabilitation and maintenance program. It's important that patients develop a relationship with a physical therapist and learn to do specific joint exercises that allow for strengthening of those joints within a refined, controlled range of motion. So even strengthening muscles to a smaller range of motion than one would typically have, in order to keep those muscles, the muscle memory that allows us to maybe not be so hypermobile, and strengthening our joints around that reduced range of motion. But then also employing that in our lifestyle. So remembering things such as bending our knees when lifting, not lifting from the back, maintaining good posture throughout the day when seated at a desk or when walking. Body awareness becomes very important for us with EDS, because again, we have that lack of proprioception and have trouble really understanding where our joints are in space, and that can lead to joint damage, disability, muscle soreness, etc. So we just have to employ a lot more mindfulness in the way that we move our body, and it takes some teaching to do that. Ultimately, though, however, almost all of us end up in the hands of a skilled orthopedic surgeon of some variety at some point with EDS. That is usually a treatment of last resort, and something that I recommend only be pursued for specific type diagnoses that have shown to improvement with orthopedic intervention, but also only after a genuine effort has been made at rehabilitation and strengthening of the muscles around the particular joint that is damaged. So again, surgery is going to be something of last resort, not only because it may not be successful, but also because of our poor wound healing. So one of the things I want to touch on really quickly and briefly, but we'll spend a lot more time on later, is the disease cycle on EDS and how any individual symptom that comes about as a part of the disease ends up becoming a part of a larger cycle, and a cycle that can really take us down to a very dark and dangerous place. The cycle generally starts with joint pain and fatigue, which is to some way, shape, or form a part of all of our lives with EDS. I mean, we become very accustomed to living with joint pain and fatigue. But occasionally that joint pain and fatigue will spike, we'll have a flare, we end up with non-restorative sleep, either because we're having trouble falling asleep, we are waking up from sleep from pain or stress or anxiety, but our body is not receiving adequate rest. This in turn creates more stress and anxiety on our body, which incidentally can lead to problems with adrenal fatigue and hormone imbalances that further reinforce this disease cycle. But stress and anxiety also, as we all know, lead to depression and despair, which in turn can lead to decreased mobility, decreased physical exercise, decreased overall well-being. Again, reinitiating the cycle of increasing joint pain and fatigue. And so this becomes a round and round cycle that just seems to get worse and worse, and mainly because each of these areas impresses on the other. So what I do in practice is I try to intervene and stop the cycle at some point along the way, and usually that requires an individual approach as to which direction or which area of life needs the most amount of intervention at a given point, and how to go about it in a way that is useful and meaningful to an individual. But for all patients, it's important for us to manage hypermobility and prevent joint damage and dislocation, subluxation, pain, muscle issues, et cetera, sleeping issues. You see, so starting with the hypermobility is important, and with that we focus mainly on preventing disease progression and disability by restoration of normal form and function. This gets back to the idea of strengthening the muscles within a normal or reduced range of motion in order to train our brain and train our body to move in an appropriate way that is safe for us. Sometimes splinting is necessary when there's been an acute injury, but I like to always point out that it's important to not splint any of our joints for too long, because that can result in muscle weakness and further laxity and disability. So I always try and teach my patients how to ascertain when it's okay maybe to pull out of the splint and work on strengthening, and when maybe it's acceptable and reasonable to put a splint on just to protect a joint that's maybe healing and collagen that is growing and developing and trying to cover an injury, but that it should not be employed long term. And then finally, there's a lot of important counseling that goes into teaching patients how to avoid high impact activities, not only in sports, but also in their daily life, but also avoiding activities that could promote hypermobility. So things like dance, gymnastics, yoga, etc. So what is helpful? After many, many years of being on a variety of different medications and going to a number of different specialists and feeling like each specialist was seeing my problem from their unique vantage point, but not looking at me as a whole, and adding more and more medicine and more side effects and more medical complications to my list, I became worse over time, actually, in my pursuit of seeking out medical help and care for my symptoms. And so over time, what I have found to be most helpful, and what many people with EDS find to be most helpful, and this actually goes for all types of chronic disease, is adhering to a healthy lifestyle that works for you in your life and is one that you can employ on a daily basis and work on a little bit every day. Get a little bit better every day. You know, big changes happen as a result of a cumulative collection of small changes. For me, I like a paleo-like lifestyle. I'll admit that I'm not perfect when it comes to employing paleo diet or lifestyle, but I certainly always strive to live in a way that is more mindful and more reflective of how we lived maybe as cavemen. This includes pursuing a diet rich in plant-based foods, nuts, vegetables, fruits, and a lower reliance on animal fats and proteins. If you think as primitive man, you know, we hunted and we did not have the benefit of having meat every single day. And so a lot of what helps us with EDS is learning to listen to our body, listen to the cues of what our body's asking from us. And I think we can all learn to listen in a little bit closer, and that goes with diet. So I spend a lot of time counseling patients on how to pursue a diet and lifestyle that is healthy and works for them with their specific disease state. For EDS, this includes getting enough rest, generally 8 to 10 hours of good, restful, restorative sleep. But on the flip side of this coin is not getting too much rest. If we linger and stay in bed, this contributes to increasing disability, decreasing mobility, decreasing muscular strength. And as hard as it is sometimes to get up and get moving every day, it's extremely important for our disease to do something every day physically. So remember, it's important, everything in moderation, including moderation. That's a quote from Oscar Wilde. So that includes rest and relaxation as well. Social support is also very important with our disease. Being able to get on some of the the social networking sites into social groups where EDS people accumulate has really helped me see that the symptoms that I experience and the symptoms that I see in my patients are really ubiquitous and common among folks with EDS. And other people are out there dealing with some of the same things that you may be dealing with and feel are just so burdensome and so difficult, and something that nobody else in your life understands. But it can be helpful to see that there are other people out there that get what you're going through and understand your plight as far as EDS. So I implore you that being on this station, looking and listening to these YouTube videos is helpful. But I also implore you to go to the social network sites, the various social network sites, and look for EDS support groups. There's lots of them. I know there's EDS Texas, and there's a national EDS support group on Facebook. These are all great. Remembering that this is not professional medical advice, but instead is people who are in the trenches with you, so to speak. So that's it for today with the presentation that I have made, giving just the basics on EDS. Please stay tuned to this station and this YouTube site, as over time I'm going to add to the video library and hopefully create a little bit of a video blog to help people get quality information about EDS and related invisible disabilities. If there are specific topics that you are interested in me covering or mentioning in any particular way, please leave a note for us at the bottom underneath this channel, or leave us a note on our Facebook page, or even contact us at the clinic. You can find our website, www.kellyclinic.net, on the internet, and we'd be happy to hear from any of you and all of you regarding your questions on EDS and invisible disability. Thank you so much for tuning in to us today, and I look forward to reaching out to you in the future with more useful topics. Thank you.